Good morning, good afternoon, and good evening to our webinar participants. My name is Thomas Krüger, and I'm Product Manager for the Babylog ventilators at the Dräger headquarters in Germany. I would like to welcome you to our international webinar conducted by Professor Manuel Sánchez Luna. Professor Sánchez Luna is the Medical Director of the Neonatology Division and NICU at the Hospital General Universitario Gregorio Marañón in Madrid in Spain. The hospital is a level 3C academic center and national reference center with about 6,000 deliveries per year. Professor Sánchez Luna's special interests are respiratory physiology, bronchopulmonary dysplasia, sepsis, shock, and nutrition. Professor Sánchez Luna was chairperson at many international and national congresses and conferences. He is member of all the main European societies and the president of the Spanish National Society of Neonatology. As everybody would expect, he has published more than 150 papers. Since Professor Sánchez Luna was also very much involved in the COVID-19 pandemic this year, in Madrid, we are happy that today he will share valuable information with us about COVID-19 and the impact on neonatology. But before we start, I would like to raise your attention to some technical instructions of our webinar system. Instructions will follow now. Your microphone will be muted during the whole webinar session. The button with the microphone is therefore colored gray, and so you are not able to speak to the audience. If you want to ask a question, use the question or chat function in your webinar toolbox on the right-hand side. Just type your question into the field and Professor Sánchez Luna will answer them at an appropriate time during or after the presentation. You can enlarge the presentation to full screen size if you like. To do so, please click on the window button. Click the button again to bring the presentation to normal size again. By clicking on the orange button at the top with the white arrow, you can minimize or maximize the webinar toolbox window. After Professor Sánchez Luna's presentation, we would like to invite you to a question and answer session. For this purpose, you can use the question or chat box in your webinar toolbar. Professor Sánchez Luna will try to answer as many questions as possible during the session and also afterwards. Please be reminded that this webinar will be recorded and can be downloaded on the Dräger website shortly after the session. Your name will not be shown at any time. We will inform you via email afterwards when the video or further material will be available online. Now I would like to hand over to Professor Sánchez Luna for his presentation. So Manuel, it's your time.
Dear Thomas, many thanks for your kind introduction and presentation. Good morning from Madrid, good afternoon and good evening wherever you are. First of all, I would like to apologize of not being in touch face-to-face with all of you, as you can understand that the current situation of the pandemic are limiting our traveling possibilities. So I hope in the near future to return and be and enjoy with all of you face-to-face. That is the way we love to be during this kind of scientific sharing. So today I'm going to review with all of you some of the data that we get from the National Society of Neonatology in Spain, where I am the current president. And much of these data are able, thanks to our Committee of Infectious Disease, chaired by Belén Fernández Colomer, and I would like to thank very special to her and to all the team and all of the hospitals that fed with their data to this registry. More than 100 hospitals were sending data to our national registry. But before going through the study that I'm going to share to you, I would like to update the current situation of the COVID-19 in our country, in Europe, and in the world. And as you can see, the number of people actually infected by the SARS-CoV-2 is tremendous. It's too high. Look, in Spain, we have more than 1,600,000 people. In Europe, 18 million, close to 800,000, and in the world, about 64 million people infected by this virus. How is the situation going right now in Spain? So you can see the two waves of diagnostic cases in the blue color. From the beginning of the month of March, you can see that we declined the number of people who were infected by the virus. And again, back in mid-July, we began to have the second wave with two small peaks. And now we are facing a very much better situation compared with the beginning of the summertime. And right now our country is not one of the highest country in terms of the number of people infected by the virus. What about mortality? So this tremendous number of people who died, you can see how the numbers were much higher during the first wave, being the peak around mid-April, and declining so far at the end of May, June, with the second wave not so high in terms of number of people who died every day in the country, but with a catastrophic situation in terms of mortality. So when we began in our country to face this situation at the beginning of the first wave, around March, in our National Society of Neonatology, we were very concerned about the way of this infection is going to harm or not our newborns. So we got only data from China studies at the beginning, and we were very concerned about the possibility that babies are going to be infected or not through their mothers, if the mothers are positive to the COVID-19. So we began very fast to touch other countries as well. I was very lucky to have the information coming from the Italian National Society of Neonatology, WHO in United Nations. With all of these data together, we began to develop a protocol in the country to attend our babies born from COVID-19. Working together with our National Ministry of Health, we developed this way of screening and act with the baby born from a mother positive of COVID-19. As you can see in your screens, the two possible situations to act with the baby born from a mother positive is that if the baby is asymptomatic, we kept the baby with the mother together, rooming in. We stimulate breastfeeding, skin-to-skin care, delayed cord clamping, and we control after discharge of the hospital in around 2 weeks. If the baby is with symptoms, we try to keep the baby isolated from the rest of the babies admitted to the hospital. And most of the time, the symptoms of the newborn were, as I'm going to show you in a few slides after, were related to prematurity or typical conditions of neonates. But when we at the beginning need to admit the baby into the ICU or neonatology ward because the baby was with symptoms, we keep the baby isolated, as I let you know. And if the baby was negative, we keep out this isolation and keep the baby in the same way of any other regular newborn admitted to the hospital. If the baby turns to positive by the test, then early after delivery, then we kept the baby isolated and controlled at the hospital. But before showing you the data of our national registry, we try to do exactly the same in our hospital. As Thomas told you, our hospital is one of the biggest hospitals in Europe, with around 6,000 deliveries per year. And one of the good things and good news from our hospital is that we have a specific isolated building for children and maternity. So we were very lucky to be isolated from the rest of the adult hospitalization in the hospital. So we try to do exactly the same recommendation that we get from the National Society of Neonatology, and we create circuits to prevent infections between mothers or families with a COVID positive over all other families without a COVID positive, because the hospital need to keep on working in the same way, because deliveries were still going on even during the pandemic. So we try to isolate families, mothers and kids in the different areas of the hospital. And this was possible. I'm going to show you how we did. This is the labor and delivery room facilities, and we prepared a special area for the pregnant women positive with the COVID-19, with isolation rooms for the family, for the pregnant and one of the person who in the family can be together with the pregnant woman. So we create this isolation for them, and then we create a protocol for delivery and attending to the neonate. So what we try to do is to prevent the infection right after delivery, keeping very high hygiene in the mothers with face masking, hand hygiene, and of course, preventing infection of the health workers. So the baby was taken care by a neonatologist as any other delivery baby in the hospital. We try to do a nasopharyngeal PCR test as soon as possible after delivery, and most of the time in the first 24 hours. Of course, we try to keep the late core clamping, skin to skin care, and breastfeeding as soon as possible as any other baby born in the hospital. So this is the area of labor and delivery room. So the mother could be in this special room, very similar to any other kind of rooms, but isolated from the rest of the circuit of labor and delivery room facilities. The mother was with one other person in the family, and the baby was taken care exactly by the same way, just preventing the infection. As I told you, from the mother after delivery, having the hygiene of the mother very close. So what to do in this postpartum care? So after delivery, the baby was able to be with the mother as any other baby born in the hospital, and the mother was even being positive for the COVID, safe in terms of no respiratory problems or any kind of condition. We keep them isolated in a rooming area and permitted one visit to the family and the couple. The diet were at the hospital as long as most of the families, around 48 hours. And then, as I told you, we kept controlling the baby after 2 weeks to know exactly how if the disease was going to be affecting the baby or not. So what about those babies who need to be admitted to the ICU or to the neonatology division? We at the hospital have isolating rooms, single rooms with negative pressure, and we create this specific area to take care of the babies with the mother or the father 24/7 with them. if they were able to be with them. Of course, we create a very secure area for hygiene before and after entering and going out from this single room with this negative pressure. So this area was used during the first hours after having the result of the nasopharyngeal PCR of the baby. So if the baby was negative, then the baby was kept out from this isolated room, and if the baby was positive, this was no baby turned in positive in our hospital after more than 80 babies born from COVID positive mothers. Well, but if the baby were still positive, the baby were remaining in this isolating area. What about those newborns coming from the ER, coming from home, suspected to be infected by the COVID? Well, we created a specific area in the pediatric department to attend the diet of the mother and the baby together in an isolation room. And exactly the same as many other babies who need to be hospitalized in the hospital, but with the extreme controls in terms of prevention of spread of the infection over the hospital. So specific corridor with a specific single rooms for the family is the way we attend those babies who were admitted from the ER from home with the COVID positive. Well, in our hospital, we have a specific, very new and innovative milk bank. We have donor milk from mothers who turn their babies most of the time prematurely. So we have the possibility of give donor milk to those babies who need to be supplemented by human milk with premature milk if they need, and with the same length of gestation. So this is what we call a personalized milk bank. So during this pandemic, we were very lucky that we did not decrease the amount of donor milk to the hospital because the donors were in the hospital, and we didn't have the problems that many other regular standard milk banks had, because the donor were coming outside from the hospital. So we were very lucky that we even increased the amount of donor milk during the pandemic, and we were able to give donor milk to our babies hospitalized during this pandemic. So we kept this recommendation that came from the National Society of Neonatology because we wanted to have evidence behind that these recommendations were really safe and effectivity results for our babies in our country. So this is why we create this national registry at the beginning of April this year. So having our results in this live registry, we were able to check if our national recommendations were really safe for our babies. Again, I want to remember you that the recommendation of the National Society of Neonatology were summarized in these 4 points: no separation of the positive COVID mother to their newborn, delay cord clamping, and promote skin-to-skin and breastfeeding. I must say that very recently, the American Academy of Pediatric also modified their recommendation very close to this recommendation that we did in Europe. So with this in mind, as I told you, we create this national registry that I'm going to show you right now the results. So these data that I'm going to show you are published very recently in Frontiers in Pediatrics, and I'm going to, it is accepted, it's going to appear in a few weeks in Pediatrics. The 2 journals show the 2 groups of babies added to the registry. In Frontiers in Pediatrics, we publish the babies who were positive for COVID, coming most of the time, as I'm going to tell you, from their houses. In pediatrics, we published the first big diet group of babies born from COVID positive mothers. And I'm going to summarize to you the methodology. So this is the first group of results that I'm going to show you. As I let you know, it is going to appear in pediatrics very soon, in a few weeks, I must say. Well, these results were fed from most of the hospitals in the entire country. The registry was real-time data from babies born from mothers diagnosed of COVID-19 during pregnancy or immediately after the postpartum period. So cases began to be included from March 8, and the results going to appear in the pediatrics were from 503 babies born from 497 positive mothers. But right now, the registry have more than 1,500 dyads from COVID positive mothers from more than 100 hospitals. So the registry is live. Probably we will have more than 1,600 in a few weeks. So this is the demographics of the mothers infected by the SARS-CoV-2, and you can see there are not many differences from regular pregnant women in the country, but we have a higher percent of the mothers with previous morbidity. As you can see, 28% of the mothers did have a previous clinical situation that most of the time were related to obesity, infertility, or hypothyroidism. So again, these data are very similar to most of the data published in other registries and studies, that obesity increases the risk of having COVID positive in pregnant women. So the mode of delivery was very different because of the beginning of the pandemic. During the first few months, we have a lot of CSET, some of them urgent CSET, because the clinical situation of the mother was sick, very sick with respiratory problems. And at the beginning, we didn't have the expertise that the baby was probably being much better inside mother in utero than outside. So at the beginning, because we have so many women affected by the COVID, the CSET ratio was very high, as high as 33% in the country. Normally we are below 12. And the indication for the CSET most of the time were related to the COVID infection. So symptoms in the mother at the beginning were moderate to severe, but thereafter, when we began to test all of the mothers, we have more and more asymptomatic mothers. And at the end of this period of the study, 50% of the mothers became positive from asymptomatic condition. So we reinforce the idea that we need to test all of the pregnant women who are going to the hospital for deliveries. This is a very important situation because of that we can prevent spreading the disease in the hospital and affecting the hospital workers. So what about the prematurity rate? We were very concerned about the high risk of being born prematurely in this kind of situation. And at the beginning, in this period, we found that the prematurity rate was 15.7%. In the country, normally we're around 7.4% of prematurity. So this gave to us the idea that probably being infected by the COVID, the risk of having a premature delivery was much higher. As I'm going to let you know after, this rate clearly declines after the beginning of testing more and more asymptomatic mothers. And right now, the prematurity rate is very similar to the standard rate of prematurity in the whole country. But at the beginning of the disease, as you can see in the first wave, the prematurity rate was very high, 15.7%, with a prematurity rate of less than 32 weeks of 52.2%. What about the care after delivery? We were able to apply our recommendation in the country. Most of the babies were given immediate skin-to-skin care after delivery, 52% of the babies, and we were able to do delayed cord clamping in very high number of babies, 43%, exclusive breastfeeding from the beginning, 54%, taking the idea that at the beginning we were a little bit afraid about the possibility of transmission of the virus through breastfeeding. And as you can going to show you, results didn't demonstrate in at least our country, our registry, any high transmission rate from breast milk to the infants. So what about the nasopharyngeal test done in the first hours after delivery in our babies born from COVID-positive mothers? So what we did is to do a first test very early and then repeat a second test if the first was positive. And as you can see, from 469 babies born from COVID-positive mothers, only 14 were positive, but after repeating the test, only one baby remained positive. So in our data, we must say that probably the transmission of in utero of this SARS-CoV-2 is very rare or very low. The only baby who was being positive remained asymptomatic and turns negative in the follow-up. But the important thing is some of the babies who were negative at the beginning turned positive. As you can see, 4 out of 144 of babies who were negative at the beginning turned to positive in the second test. Most of these babies were infected after delivery, being in touch with the mother, but the rate of being infected is very low, as you can see, 2.7. So the recommendation of hygiene were very well followed by the hospitals, and as you can see, this recommendation turns into a very safe way of taking care of our babies in the country. So this is the flow of the neonates born from positive mothers. We have only one baby who died, 502 alive. Most of them were asymptomatic and appeared symptoms in 98. What about the symptoms? Most of the symptoms were related to prematurity or standard conditions of neonates. So the hospitalization rate was very low. And you can see that for the 197 babies who need to be admitted to the hospital after delivery, admitted to the ICU or the neonatology ward, most of them were because it was difficult in some of the hospitals to keep the rooming in with the mothers, or because the mother had a severe condition, clinical condition. So only some of the babies were really admitted to the hospital because they developed symptoms. And as I told you, most of these symptoms were related to prematurity or standard neonatal conditions. So what about the follow-up? We follow most of the babies born in the country. We lost only 57. And as I show you here, all of them on the follow-up babies were healthy. after this follow-up period. So of course we have some limitation of this data because this is a national registry, so it is not a clinical study or a scientific study. It's difficult to have all the information, but we have real numbers in a very huge population of babies born from COVID positive. So in summary, the key conclusion of our registry of babies born from COVID positive is that right now symptoms in the mothers are not much more higher or frequent related to the general population. Some of at the beginning, some concern was coming from the idea that most of the mothers who were positive were having symptoms because we didn't test all of the pregnant women. When we began to test, we got a lot of asymptomatic mothers. Half of the population were asymptomatic, as you can see. So this reinforced the idea that all of the pregnant women who are going to the hospital to be giving the baby must be tested from the COVID-19. What about the prematurity? As I told you at the beginning of the wave, the rate was very high, and thereafter, as I'm going to show you later on, this prematurity rate decreases most of the time. We were able to apply the recommendation of the National Society, doing skin-to-skin care, delayed cord clamping, rooming in, breastfeeding from the beginning without any kind of adverse event. So most of the neonates did not require to be hospitalized or admitted to the ICU or the neonatal ward, and only a few of them, 98, were admitted, and most of the time symptoms were related to their prematurity. So I'm going to show you now the other second part of the registry results. These are the babies who in the country were infected by SARS-CoV-2, and this is the areas where the babies were coming from. Most of them were coming from the area of Madrid, as we have 6 million inhabitants. Cases were 40 only in this first study, published in October a few weeks ago. So the 40 cases were divided in two groups. Most of them were cases acquired at the community, probably infected by the family when they were at home, and only 14 probably were infected during the hospitalization after delivery. So here you have the 26 cases acquired at the community. Only 8% of the cases were prematurely born babies. 5 were asymptomatics, and symptoms appears in 21. So of them, 19 required to be admitted to the hospital, and only 4 were admitted into the ICU. Well, the 22 cases without symptoms or mild symptoms are described here in this slide, and you can see the symptoms in these mild cases were upper respiratory symptoms, fever, or acute gastroenteritis, or ADS, very, very mild, with leukopenia or changes, not severe changes in the X-ray of the thorax. One case were treated at the beginning of the wave with some medication that today we know that there is no way to be given. Who were the babies that needed to be admitted to the ICU? 4 cases. 2 were twins with pneumonia. Both the parents were positive with the COVID, and the babies were doing well and were discharged from the hospital after 6 days. They were treated in this hospital, again, because at the beginning of the wave, there were some concern about giving this kind of medication. Today, we know that there is no room for treating these babies. One baby was admitted to the hospital because of bronchiolitis, was a term baby. This probably we don't know exactly if the COVID did something in this baby or not, because the baby was positive with the rhinovirus. And the rhinovirus clearly was probably the etiology of the bronchiolitis in this baby, who were discharged from the hospital after 32 days. So this was a severe case of bronchiolitis. And one baby with apnea that was doing very well. What about the 14 cases that probably were acquired the infection at the hospital? As you can see, all of them were going very well with very mild symptoms, fever, 2 cases, upper respiratory symptoms in 5 cases, and very mild acute gastroenteritis or dehydration in 1 each. So probably 6 of the 14 were infected by the mother, and the rest probably through the medical workers. What about these mild cases? And as you can see, only 2 cases were treated, as I let you know before, because at the beginning of the wave, there was some concern about not giving medication to these babies, but the babies were doing well, and these 2 cases were treated because they have a severe combined immunodeficiency by CB infection. So this was the reason that the doctors of these babies treated them with hydroxychloroquine. So this is today the picture of the pandemic in our registry, and you can see very nicely how the 2 waves appears. The very first wave decreases at the end of May, and the second wave began again at the beginning of August. So today we have more than 1,000 mothers infected by the COVID, sending data to the registry. And today you can see the age, mean age of the mothers are 32 years of age. This is very similar to the mean age in our country, 32 years for the first pregnancy. And as you can see, again, gestational problems appears in 5% of the mothers with gestational diabetes, and 7% of the mother again were obese. So most of the mothers were infected at the end of the pregnancy during the 3rd trimester. So what about the prematurity rate? In your right-hand side of the slides, you can see in the blue color the term babies born, and in the orange the preterm. As you can see, during the first wave, mostly during March and April, numbers of premature born babies were extremely high. But around May, June, the end of or the beginning of the summertime, this number turned to very low. Again, began to increase in July and decline again in August and September. So at the end, regular numbers are lower than the mean numbers of prematurity are lower at the end compared to the first wave. And what about symptoms? Well, symptoms in the babies born appear to be related to the prematurity. So you can see here in your left-hand side of the screen that most of the babies who turned with symptoms were premature born babies. So today we have 37 positive cases of babies born from 1,052 mothers COVID positive. Out of these 37, only 2 of them were positive after 48 hours, so in the second test. And in these 2 cases, babies were asymptomatic. So again, we can't clearly say that this infection is going to be transmitted in utero. From the 833 babies who were negative, 7 turned to positive in the second test. And these 7 were, most of them, as you can see in the slide, asymptomatics. Only 1 baby were beginning to have symptoms, but with a very mild respiratory distress syndrome treated with nasal CPAP. So all the babies who turned positive in the second test were doing very, very well. So I want to thank here before finishing to all of the people who were working in this registry, to the executive committee of the National Society, and of course to the infectious disease committee chaired by Belén Fernández Colomer, who was really the soul of this registry. And thanks to all of the investigators of the 110 hospitals in the system registry of Spain. Without them, we weren't able to have this data. Today, the registry is still alive, and we are still looking at the effect of this pandemic in our newborns. We are going to keep this registry open probably during the 2021 year to know exactly how the effect of the co-infections of the typical winter virus in our country, or the effect of the vaccination in mothers from now will affect or not to our newborns born from mothers with a COVID positive mother. So in summary, before finishing, I must say that from the neonatology point of view, we have to transmit calm to the society, calm to the mothers, calm to the families. Number 2, we have to repeat that probably the risk of transmission of the infection from a pregnant positive mother to their in utero baby is very rare, or probably do not exist. Only a few cases have been described, and these very few cases probably are very strange or very rare. Number 3, babies don't have to be separated away from their mother's positive if the mother and the baby are doing well. And I think it's extremely important to prevent this separation of the mother to their born baby, because we will decrease the risk of colonization from other bacteria. We can probably prevent stopping breastfeeding, the standard care of the babies after delivery. So skin to skin care, breastfeeding, and delayed cord clamping is a very safe condition. We don't recommend wash up the baby, or washing the baby, or clean up the baby, or separate the baby from the mother, because this doesn't mean any beneficial effect to their babies. What we wanted to transmit also is that we need to still watch our babies in terms of what is going to be in the near future. Follow up the babies who were born from COVID positive mothers, follow up the babies who turn positive after delivery, and keep on studying and watching in this pandemic situation babies from mothers positive or being positive by themselves. So this is what I wanted to let you know and share with you. And now I'm very happy to answer your questions or comments. And thank you very much for your attention. Thank you.
Thank you very much, Manuel. I think this is great data from the National Registry. And we are looking as well forward to see how this data will develop over the next month. I think this will be very interesting. So now we will start the question and answer session. Please ask your question via the chat function in your webinar toolbox on the right-hand side. So I will now look for any questions which appeared there, and then we'll read this to Manuel so that he can answer this. So far, we see no questions at all. Let's see how this will go on. So please use the, if you have any questions, then please use the chat or question part of your controls on the right-hand side. You see there the special area for chat and or for question. And please type in wherever you like. And so we will try to, or Manuel will try to answer your question. So Manuel, everything seems to be pretty clear. So there are
I'm very happy with that. Yes,
yeah,
absolutely.
I mean, that's very good.
Mm.
I mean, it was really, it's as I said, very fantastic data. And as well, I mean, as you said, it's a good evidence and proof and check that this, what you are doing today, is safe and is good. And there's no reason to change this. I think that is really very valuable information, because I can imagine that many people in the world have doubts how they do it right, and possibly will separate mother and child, and without any reason. Yeah. And so I think this is a fantastic data which helps not only in Spain, because you are providing this data as well to these webinars what we are organizing. So I still see no questions. There's one popping up. Let me read this for you. So this is from Indonesia, obviously. Good afternoon. I'm Daisy from Indonesia. I want to ask you, if we don't separate the baby who born from mother with COVID-19 and allow them to direct breastfeeding, should the professional healthcare worker accompany the mother while breastfeeding?
Well, we recommend to do exactly the same as we were doing without the COVID, but protecting the hospital workers against the infection. So it's extremely important to remember that the person who is infected is the mother, and probably the family around. So we have to take care of our workers at the hospital, and we have to give to them all their needs, or the tools, or their factors that are going to protect them from the infection. With that in mind, we have to take care of the mother and the baby in a very similar way as any other mother or baby without the infection. So protecting the baby against the mother using face mask and having hand hygiene is enough to protect the baby. And protecting the workers of the hospital against the risk of being infected by the mother is enough also to attend. But we have to remember that this infection is in high risk from the mother mostly, or most of the time. So the people who are closer to the mother are in the higher risk to be infected, and those people need to be protected against the virus.
Thank you, Manuel. There's another, at least a comment. I don't have question with the speaker, but I want to comment that here in Fils, some hospitals are separating the newborn and their mothers after birth, especially when the mother is still waiting for the swab results. Yeah, so this was Catherine. Because another question is here, because they are also protecting health workers who assist on breastfeeding. So this was an add-on to this comment. Okay, so we see that it's treated in other hospitals in a little bit different way. but I think that's just normal. So far, no more questions or chat comments. Yes, I think we wait another, let's say, minute. So everybody who wants to ask a question, please type this in now so Manuel can answer this. Otherwise, I can already say a few words. After we have closed this question and answer session, you will receive later an email with the link to the recording, what is done of this webinar. So you will definitely get this later. So if you would like to go back to a specific part and watch this again. Yeah, so still no new question. So then I think we will officially close this question and answer session. Thank you very much for logging in to our webinar, and thank you, Professor Sánchez Luna, for conducting this webinar with us. We would be happy also if we receive your feedback for today's webinar. So goodbye and have a nice day. Bye-bye.
Bye-bye.